Okay, should we? Yeah. Hi friends, good evening and welcome to our webinar of Indian Arthroscopy Society. We are lucky today that we have a master in shoulder, Dr. Pascal with us. He is an authority in Arthro-Latarjet, and it has been effort of Dr. Samanta to have Dr. Pascal with us for his master class on Arthro-Latarjet. We are also thankful for him to have Miss Jacqueline Laundre with us, and these both are going to share the views about arthroscopic Latarjet technique with all of us. Dr. Samanta, if you can just introduce briefly Dr. Pascal, and we can then start.
I think Professor Pascal Boileau doesn't need any introduction. As his name is that great because we have all been learned so many things for his tricks. We have all been there to him, and we have been trying that in this lockdown period. Probably Prof will come and interact with us, and he will share his experience. And my special regards from all corners of India to Prof. You, sir. Then I will especially thank to Jackal Audrey because I don't have that every time I am fearful that whether I should write to him or not. So Jackal Audrey is the medium. So every time I tell her, please tell boss, we are going to go ahead with this program. So thanks, Jackal. And I invite all the faculty here, all my members in the country, and all the members in the Indian Orthopedic Association to listen to the Pascal live. Thank you.
Yeah, Pascal, you can go ahead.
Yes, Pascal, it is all yours.
Thank you very much. It's a great pleasure and it's a big honor for me to organize this webinar with you. And I really want to thank Dr. Chaudhary, Dr. Oberoi, and Dr. Samanta, and all the Indian Arthroscopic Society for this meeting. So you probably know that I've been in India in 2017 to the Delhi Arthroscopy Course, and we had very good time, and we performed actually the first arthroscopic Latarjet in India with Cortical-Button fixation with the help of Dr. Chaudhary and his team, and it was a very great time for me and for Audrey. So let's talk about the arthroscopic Latarjet, and let's see why we have evaluated in this direction, and especially the fixation with a suture button and the use of a guided technique, arthroscopic guided technique. I think this is very important. So unfortunately, Bankart procedure is a very nice procedure, and I love this procedure, but this fails sometimes, and basically we didn't know initially why it failed. But in fact, it was related to our incompetence to select the right procedure for the right patient, I think. So we have tried to look for the risk factors for recurrence instability after this operation, and we developed a score that you probably know, which is the Instability Severity Index score. And what we found is that the age of the patient, less than 20 years, the practice of contact sport in competition, and the presence of hyperlaxity and bony lesions were really the main risk factors for failure after arthroscopic Latarjet. And this is the problem here. This is summarized on this slide. I think this slide is very important because
Pascal, your slide
you need to share your screen.
Screen is not been shared now.
We can't see your presentation.
I'm sorry. Oh, why not?
Just the share screen button, green button on the bottom toolbar.
Yeah. Can you see it?
Yes, now it is coming.
Yeah, now it's
Yes.
okay.
Yes,
Yeah.
all good.
So you can maybe go back to the first slide then.
Okay, I go back here.
Yes, great.
This was just to show that we were in India in 2017 to do the first arthroscopic Latarjet with the Cortical-Button fixation. And this is why we want to speak about. Okay, now it doesn't. Okay, we want to speak about that, about the possibility of doing this operation to avoid the failure of the arthroscopic Latarjet, of the arthroscopic Bankart, sorry. And what found with the Instability Severity Index score is that beside the age of the patient, the young patients less than 20 years, and when they practice sport with contact or overhead, and when they have bony lesions and hyperlaxity, are the patient at risk for failures when you do an arthroscopic Bankart. And this is why we developed the Latarjet procedure. And I think this slide is very important. And if you have to remember only one slide, is this one, because I think there is a misunderstanding. People are talking about the bone loss, and they don't speak about the elongation of the anterior capsule and the inferior glenohumeral ligament. And this is very important to understand because the two are linked. This is not either a problem of bone loss or a problem of soft tissue deficiency. Both deficiencies are present in most of the patients. And this is why this is very important to do the Bankart operation. But if you work with the elongated tissue, I mean, this will not be strong enough to avoid the recurrence of instability. And this has been shown nicely by Christian Gerber and his team. And we have had the same experience before. If you follow your patient with Bankart, and if you follow your patient with Latarjet, Latarjet is a plateau. You don't have late failures. And the problem with the Bankart is that the more time passes, the more failures you can observe. So that's the main problem because people don't go back to sports. They have a stable shoulder for the daily life, but not for practicing sport. And this is a key element here. This is the inferior weak point of the shoulder. When you put the arm in the at-risk position, in the throwing position, you can see that only the capsule and the labrum is here to stabilize the shoulder. And the beauty of the Latarjet procedure is that it allows you to have this sling effect in addition to the bony effect. And that's the key point here as shown on this drawing. The Latarjet procedure is a dynamic operation. So it's not only a static operation, it's not only the bony effect that we are looking for, but also the dynamic effect of the lowering of the subscapularis and the sling of the conjoint tendon, which prevents the humeral head to get out of the socket and to have a recurrence of instability. So here is Michel Latarjet. He has proposed to do this operation in the 50s. And this is a patient operated by himself. And this is an X-ray that Gilles Valch gave to me. This is an X-ray of a patient 52 years after an open Latarjet. You see that at this time, Latarjet was using only one screw, and you have a perfect bone block healing, and you have not much arthritis 52 years after this procedure. So screw fixation is the gold standard, and Gilles has developed the technique with two screws, two Malero screws or two cannulated screws, and doing the Bankart procedure in the same time. So in the next minute, this is what I would like to do to share with you. It is first of all to see with you why you should stop using screws for this operation, why you should start using cortical buttons to do the Latarjet, either open or arthroscopic, and why you should, more importantly, use a guided technique for doing the arthroscopic Latarjet. So let's start with the first chapter. Why should you stop using screws for Latarjet? This is a very important question. For many reasons. The first reason you see is that it's very, very difficult to implant the screw strictly parallel to the glenoid surface when you come from the front. And if the screw is oblique, this leads to impingement, which means painful shoulder and osteoarthritis in young patients, which is very bad. And also, even in the best hands, you see, this is a series published by Gilles Valch in 2014. This is open Latarjet, and you see that there was 20% of incorrect bone block positioning, even open, 77% medialized bone block, 13% lateralized bone block, and potentially some arthritis. The problem with screws is that when you try to do it under arthroscopy, it's even worse because it's very, very difficult when you come, and very dangerous, we're going to see that, when you come from the front with a screwdriver, with a drill, and with a screw to try to fix the bone block. Why is it dangerous under arthroscopy? Because you're coming through a medial portal. That's the only way to be parallel to the articular surface. And here is the axillary nerve and the musculocutaneous nerve, and they are at risk, especially when you come with your drilling machine. And when you come with your screwdriver, you can easily make injuries to the brachial plexus and to the vessels over there. And this is not acceptable to have an axillary nerve palsy, for instance, in a young patient after a Latarjet procedure. This is a disaster, which is, I think, not acceptable. And also posteriorly, you have the suprascapular nerve, and because it's difficult to be parallel to the glenoid surface, very often you are oblique, and you can catch branches of the nerve or the nerve itself with the tip of the screw. So again, this gives pain, and this is a problem. But also there are many mechanical failures. Screw pull out, screw bending in case of recurrence. You never know, you can have a recurrence. And even if it's well done, if you do an X-ray, you see it looks very nice on the X-ray. But if you do a CT scan, you will see that you have only partial compression, even with a screw, because it's very difficult to manage the compression of the screw without breaking the bone block. And the problem with screw is that under arthroscopy, the people who do arthroscopic Latarjet with screws are now removing the screws in many patients. This is a paper from Thibault Lafosse and Laurent Lafosse, where they show how to remove the screw under arthroscopy. And this is a paper from Rettinger, who is a former fellow of Laurent Lafosse. You see, he has made a very nice study, actually published in one of your journals, the Indian Journal of Orthopedy in 2019. And he has reviewed 132 patients. And you see that at the end of the day, he has to reoperate 40 shoulders, which means 30% of the patients, either for an hematoma, for a broken K-wire, for a removal of the screw, for neurovascular complication, for recurrent instability or stiffness, etc. It's a high rate of reoperation. And very often now they have to go back to remove the screws, as you can see here in these pictures. So the second question we would like to ask is, why should you start using cortical buttons for the Latarjet, even if you do it open? Because I think the buttons are better than the screws. And I'm going to demonstrate this to you. So we started in 2013 with a cortical button fixation. And it's a very funny story because it started with myself doing a Latarjet procedure, and I broke the bone block, and I didn't know how to fix it because the piece of bone was too small. So that's why I get the idea of using a double button to fix this very small piece of bone of coracoid process. And I follow the patient with CT scans, X-rays and CT scan, and I saw that this patient healed his little piece of bone block. So that's why I started to do a series of patients and then to develop a specific button for this purpose. But it started with a complication of myself with the failures that I had. And basically, what I want to demonstrate today is that a cortical button fixation, a cortical button is nothing else than a bolt or a rivet. This is a bolt, and this is mechanically, of course, superior to a screw. Every engineer in the first year of study know that. You don't have to be a genius to know that. Why? Because what you're doing with the bolt is that you are fighting against tensile forces, and you want to transform them into compressive forces. And you can do it with a screw, of course, but this is what happens if you do it with a screw. This is the pressure cone that you obtain. You see, the green is the bone block, the orange or the brown is the scapula, and the cone of compression is very small, just on the bone block almost. And this is a cone of compression that you obtain when you use a bolt or a rivet. You see that there is compression in all the thickness of the bone block and the glenoid bolt. So this is very interesting in terms of compression, but also in terms of resistance to pull out. And how do you obtain that? You obtain that by using a tensioner. And this is something that I learned also from my mistake, because initially I was just tying knots like this without compression, without tensioning the suture. And you can obtain healing, but not 100%. While when you use a tensioner, you transform this soft suture into a rigid bar, and you obtain the equivalence of a bolt. And this is nicely shown here on this glass model where you see that the suture is really a bar, exactly like a bolt or a rivet. And mechanically, you don't need to use 4 buttons. 2 buttons, one in the front, one in the back is enough. And this will be superior mechanically to 2 screws. There is no problem with that. So you're going to tell me, oh, that's not possible to, that is solid enough because this is just a suture. This is not metal. We prefer metal. But you are wrong if you say that. Why? Because today, textile is replacing metal everywhere. If you like sailing boats, like myself, you would know that on the sailing boats, they replace everything they can, which is in metal, with textile. Because today, textile is as solid as metal. I mean, the progress that have been made in the industry for developing very resistant textile is unbelievable. So now, why you should forget about screw fixation? Just because there is no single screw in a plane. If you take the plane, today we are locked down and we cannot take planes. But when we were taking planes, if you remember, and if you look to the wings of the plane or the fuselage of your plane, there is no one single screw. Every pieces of metal are fixed with bolts because this resists more than the screws, and this, in addition, resists to the vibrations of the plane. Last question we should answer is why you should start using a guided technique for arthroscopic Latarjet. Because as you can see, if in a moment, if you follow all the steps, you're going to end up with the same results than myself. And for that, you should start with a good location of the portals, arthroscopic portals. You can see here, number 1, that the coracoid process is directed toward the axillary fold. And so the north portal is medial to the coracoid process, while the south portal is in the axillary fold. Then you have the lateral west portal, and then you have the east transpectoral portal, and you need an additional northwest portal to be orthogonal to the coracoid process. It's very important to follow the steps one by one, because if you do this way, I mean, you end up with the same result. So let's see the different steps. Coracoid preparation. Of course, you need to prepare the undersurface of the coracoid. You need to drill that, and you need a specific guide. Sorry. Then you need to shuttle the peg button, and then you can do the osteotomy of the coracoid process. Now, second step is the glenoid preparation. Again, you use a motorized rasp to prepare the neck of the scapula. And then instead of drilling from anterior to posterior, the key point here is that you are going to drill from posterior to anterior, which means there is absolutely no risk. You're going to come from back to front, and it's going to be controlled drilling, and there is no risk for the brachial plexus, number 1. And number 2, you're sure you're going to be strictly parallel to the glenoid surface. So you're going to put your guide at 5 o'clock. It's going to be 5 millimeter medial to the glenoid surface, and you're going to come with a specific K-wire, which has 2 parts, as you can see, male and female. And then you will do your spread, the subscapularis split, which is the third step, with a spreader coming from posterior, which is going to open the subscapularis muscle, and a second spreader, which is going to come from anteromedial, from the transpectoral portal. And this instrument, this spreader, is very important because it is a nerve retractor. Then the last step is the coracoid transfer from front to back. Don't forget to put the second button, which is a single hole button. And then you can tie the Nice knot, which is very simple. It's a square knot. And then you pass the 2 free hands in the loop. And this gives you a sliding locking knot to get the compression first. And then you use the tensioner to transform the soft suture into a rigid bar. And then you add 3 other knots to lock everything. So this is shown on this video animation. As you can see, first step, coracoid process. Second step, glenoid preparation and drilling. Third step is split of the subscapularis from the front, from the back, and then transfer of the coracoid process from the front to the back against the glenoid neck. Then addition of the posterior button, tying of the Nice knot, tensioner, and then compression of the bone block, and then additional nuts, 3 nuts to lock definitively the construct. So why you should not wait to start to perform this guided suture? Because it's very reproducible, and all my fellows who leave the department knows how to do this operation, I promise you. So this is a short video that I made for you to show you the technique. You see the 5 anterior portals. You see the scope, which is in the standard posterior portal. Here you see a heel sac lesion. You can see how we choose the northwest portal just in front of the acromion, so that we can clean the rotator interval, and we look for the subscapularis. And following the subscapularis tendon, we go in direction toward the coracoid process. We can identify the coracoid process and the conjoint tendon. We can then do the north portal, which pass through the pec minor. Then we can detach the pec minor tendon from his medial insertion on the coracoid process. And everything is done with the scope posteriorly, as you can see, going through the rotator interval. Then using the motorized rasp from the anterolateral portal, we can prepare the undersurface of the acromion. Then we do the 3 other portals in one step here. And coming through the south portal here, we're going to put a temporary PDS suture around the tendon. And then we're going to come through the north portal with the coracoid guide. This is very important to see the medial arm of the guide here, so that you're going to be 5 millimeters on each side and 5 millimeters distal proximal to the tip of the coracoid process. You can remove the male part of the K-wire. You can insert a PDS. You can retrieve the PDS through the lateral portal here. And you're going to shuttle your implant here, which is 4 strands of sutures, white suture, with a peg button, which comes through the nose portal. And you're going to see that we implant the peg button in the coracoid process here. Then there is a step of suture management. You're going to retrieve the blue suture to the south portal, the white suture to the north portal, and you're going to put this waiting for the rest of the procedure. Now, still with the scope located posteriorly, you're going to make the osteotomy of the coracoid process, and you're going to start the second step, which is the glenoid preparation and drilling. You see that we put a stick through the lateral portal to push away the labrum and the capsule, and we introduced the coblator instrument to detach fully the labrum and the capsule. Then we pass a suture at 5 o'clock here, and this suture will be used for the Bankart repair later. And we put some tension on this suture so that we don't damage the labrum and the capsule during the glenoid preparation. Again, using the motorized rasp, we have made a nice cancellous bed for the ball block. Now we put an anchor at 3 o'clock here for making the Bankart repair. This is also a landmark to make sure that we will not put the ball block at the wrong position. Now, for the first time, we have changed the scope of place. We put the scope to the anterior superior portal, and we introduce a glenoid guide through the posterior portal. And you see that we use a half pipe so that we keep the tract with the portal. Here we can hook the anterior neck of the scapula, and with the scope in the front, looking here, we can see what we are doing. We drill from posterior to anterior, and again, we're going to use this K-wire to bring the suture posteriorly. In the meantime, we put the male part of the K-wire again. We remove the glenoid guide, and we introduce the posterior spreader, because now this is going to be the third step. We push the spreader to the subscap muscle at the same level as the K-wire, and we put the scope now in the lateral portal, and we introduce the vapor to the south portal. And we can find our spreader coming from posterior. We can use a retractor to protect the nerves, and you can see the 2 nerves here, the axillary and the musculocutaneous nerve. And we can gently open the posterior spreader here through the muscle of the subscapularis. We have a locker which is placed against the skin so that it doesn't go forward. And we can finish the dissection here. We can finish the opening of the subscapularis. Now we use with degrees of inclination the cannula here that allow us to bring the second spreader, which comes from anterior and which is very important. This is not dangerous, this is needed because this is the instrument that protects us from the brachial plexus. Now we can do this fourth step, which is the Coracoid Transfer, which means we have to reintroduce the PDS and the wide suture inside the joint. We make the shuttle, we bring the suture, PDS and wide suture in the back of the shoulder here, and we're gonna remove the PDS and pull on the suture to bring the coracoid process in contact with the glenoid neck. So we play with the spreader so that we gain some room here, and then we pull on the posterior suture, and this put the bone block in the right position. We put clamp on the suture posteriorly, we add the posterior button. Don't forget this step, this is very important. And then we can tie our sliding locking knot, the NIS knot here, as you can see, which is very simple. And by pulling on the suture, we're gonna bring together the button and the knot inside the shoulder. So we remove the clamp here, we pull, and you can see the button going inside. And now we put the tensioner on the suture, and we first put 25-50 newtons of tension, no more, because we need first to control the rotation of the bone block. Now we can remove the posterior spreader and put back the scope posteriorly, and we can check the position of the bone block, and you don't have to worry. This is always a perfect positioning because this is a guided technique. There is mismatch between the drilling of the coracoid and the drilling of the glenoid. And then you can do the Bankart repair, and then you can put 100 newtons, and you should go at least twice or 3 times to make sure you have good compression. And you can see the positioning of the bone block. And when you remove the anterior spreader, immediately all the brachial plexus is coming here because it's very close. So, and now we've added the 3 knots in the back to make the construct finished. So this technique, first of all, is very accurate. As you can see, in 100% of the time, almost you can put your bone block below the equator because you control everything with the scope. Also, the positioning, as I said, is very automatic for the glenoid surface. It's flush to the glenoid surface, and there is no possible misplacement of the bone block, basically. Because as I said, there is mismatch between the coracoid process and the glenoid, the coracoid and the glenoid drilling. If you see here in these studies that we have published last year with more than 130 cases, the positioning was perfect in 95% of the cases. Regarding the bone block healing, this is the same. This is what you have at 2 weeks. This is what you have at 6 months. This is really a good rate of bone block healing. You see 97% of bone block healing in our studies. And you see the nice remodeling of the bone block on this 2D CT scan image. Also, we didn't observe any neurologic or vascular complication in this series. And it's very safe, reproducible, and efficient, as you can see here. And more important, there is no loss of mobility, especially if you don't put your patient in a brace in internal rotation, because then it will limit motion because the conjoint tendon will heal in the tendinous part of the subscapularis instead of the muscular part of the subscapularis. And all these patients were able to return to sports, including very demanding sports like collision sports or contact with overhead sports. And of course, in the ladies, like this very young lady, you see that has been operated in another center with the open Latarjet. And when you ask her, what do you prefer? Which operation do you prefer? I mean, in terms of aesthetic, in terms of pain, in terms of rehabilitation after the surgery, I mean, she said there is no photo. I mean, I want the arthroscopic technique that's much better. And you can see here that when you do an open Latarjet, you put 2 screws, but you can see that it has been shown nicely by many surgeons, and especially by Di Giacomo from Italy. You have resorption of the upper part of the bone block, and then your screw is alone, and your screw is rubbing against the subscapularis tendon and making damage to the subscapularis tendon. So there is no need to put 4 buttons because you have the same remodeling when you do an arthroscopic Latarjet with cortical-button fixation. And also, people sometimes say, oh, but the transpectoral portal is very dangerous and that's not very nice for the ladies. I mean, I must tell you, I've done, I don't know how many now, probably more than 1,000 arthroscopic Latarjet with this technique. I have never had any lady that has complained about the aesthetic of the medial portal on her breast, as you can see here. So this is what the score of the open Latarjet, and this is the X-ray comparing the two procedures in this lady. And again, as I said, all the people that have the 2 procedures, one open with screws and one with buttons, and prefer the buttons operation. So let's come to the take-home message. The guided surgical approach is very important because it improves the accuracy of the technique of the bone block positioning. And the cortical button is really more than an alternative to the screw fixation. I mean, it's something that is, I will never come back to the screws, never ever, because it's better mechanically and it provides the same benefit in terms of position, compression and positioning of the bone block. This technique with the cortical button fixation makes the arthroscopic Latarjet simple, safe, solid, and reproducible. And forget about the screw fixation because the screws are a source of complications and of revision of the patient. It's difficult, it's unsafe, and it's non-reproducible. And for me, it is clear that mechanically the screws are superior to the bolt is superior to the screws. And next time you take the plane, look through the window and look at the wings of your plane and the fuselage, and you will see that there is no one single screw to fix all the pieces of metal. So have a safe trip back next time you travel. Thank you very much for your attention. And I take the opportunity to just let you know that on July 9 to 11, we organize the knee shoulder course in a form of a virtual meeting. And it will be the first interactive virtual knee shoulder course. And this will be on July 9, 10, 11. So please join us on the web, through the web. This is the address, kneeshouldercourse.com. And you will see that it's going to be very interesting. And I hope to meet you there. Thank you very much again for your attention.
Thank you, Prof, for your excellent deliberation. There is a question from my very close friend Sanjay Desai. He is asking, in your cases, every time you met with more than 20%, or what is your classic indication of doing this Arthro-Latarjet?
In terms of percentage of patients with
yes,
bone loss,
percentage of bone loss, glenoid bone loss, or else you do check the bipolar lesions.
If there is bone loss, I do the Latarjet, no question.
Any percentage he's asking? Any percentage like 10%, 15% is still to go with the banker, or go ahead with the classic your Latarjet, Arthro-Latarjet?
No, I do only Arthro-Latarjet.
Pascal, the question probably was, what is your threshold for offering Latarjet over Bankart? What is the percentage bone loss to make that decision for Latarjet?
So my decision process is made, first of all, is based on, on the instability severity index score, which means I ask the patient, how old are you? Less than 20 years, 2 points. What do you do sport in competitions? If the answer is yes, 2 points. If you're doing a sport at risk, it's 1 point. If the patient, I examine the patient, if he's hyperlax, it's 1 point. If there are bony lesions on the glenoid side, it's 2 points. And if there are bony lesions on the humeral side, it's 2 points. So it's a 10-point score. And we have shown, other confirmed that if you have more than 3 points, there is a high risk of failure if you do an arthroscopic Latarjet. So first of all, using the score is very important. Number 2, looking for the bone lesion, for the amount of bone lesion. And it's a combination. It's just not the amount of the percentage of bone loss that is taken into account. Because for instance, imagine that you have a patient with no bony lesion. No bony lesion, but he's 18 years old. He's doing American football or rugby. And he's hypolax, so it's already 5 points, you know. So I'm not going to do a Bankart in this case, because I know that this guy, if I do a Bankart, either he will not go back to sport or he will have a failure. So for me, the decision about the amount of bone which is lost is only part of the problem. And again, as I said during my talk, I mean, there is a misunderstanding. People think separately the bone loss and the soft tissue. No, the two are linked. I mean, the people, the patients who have the more bone loss is the one who have subluxations. It's not the one who do dislocations, because dislocations, after 3-5 episodes, they get operated. Subluxations, they wait for 100 of subluxation. And they don't even mention this to you because they live with that and they don't really care about that. But the problem is that if you don't pay attention to that, if you don't ask them carefully if they have subluxation, if they have popping in their shoulder every day, they will not tell you. And if you ask them, you will then make the calculation and you will end up with 300, 400, 500 subluxation. And then you will realize, oh, this capsule, this ligament cannot be normal. So our main problem is that we are good at measuring the bone loss, but we are not good at measuring the capsule elongation. And the beauty of the Latarjet procedure is that it takes into account the two parameters. It takes into account the bone loss because you do a bone graft with the Coracoid process, but it also takes into account the stretching, the overstretch of the capsule with the sling effect and the lowering of the subscapularis. So my indication, it's more than 80% of Latarjet actually.
Pascal, hi, Sanjay from Mumbai. Hi, how are you?
How are you?
If I rephrase the question, we appreciate that glenoid bone loss independently is not sufficient. You have to take into account other things. We appreciate that. But if I ask you, if you can isolate in what percentage of your patients is glenoid bone loss more than 20%? Just dealing soft tissue and humeral bone loss. I want to know in what percentage of your patients is glenoid bone loss more than 20?
It's about at least 50% of my patients have more than 20% of bone loss.
Okay, thank you.
If Pascal, I can,
yeah,
do you, based on Giacomo's study, do you agree on Wolff's law that if we were to do a Latarjet without bone loss, eventually that bone would osteolize?
No. I mean, if you do it, I mean, if you prepare the glenoid neck, the problem is that if you have no glenoid bone loss, you have to create a kind of glenoid bone loss because you have to prepare the glenoid neck. Otherwise, it's true that you will have no cancellous bed for the coracoid process to heal, and then you will have resorption of the coracoid process. But the key point is to abrade the glenoid neck with the burr or with the rasp.
Prof, I've got a question to you. This is a question from one of my junior, is that when you do your e-portal, what is the trick of doing it and how you take care of your axillary nerve?
So the east portal, the transpectoral portal,
yes,
is it is 3 fingers medial to the axillary fold. And the key point is to orient the cannula 45 degrees directed toward the coracoid, the base of the coracoid. So by going with this direction, what you are doing, you are passing only through the pec major. That's the only thing you do. And at this level, there is no nerve at the pectoralis major muscle. So you pass the pectoralis major, and then you watch with your scope, and you see your cannula arriving just between the brachial plexus medially and the bone block laterally. And then you do it under visual control. You go forward, and then you reach your window through the muscle, and then you can open your spreader from the front. So it's not, I can tell you, as I said, I have done more than 1,000 cases. I've never had any neurological or vascular complications. I touch wood. You can always have one day. But I mean, I've never spread this technique before I was sure it was safe. And the medial portal, I made many dissection in the anatomical lab to understand how it should be done safely. And I can tell you that if you do it the way we do it, you will have no problem.
Yes.
Pascal, there is a question there. Do you still do any open Latarjet?
I've started the arthroscopic Latarjet in the first cases. It was mini open. It was half arthroscopic, half open small incision in 2000 or 1999, and I quit definitively in 2006 to do a full arthroscopic Latarjet. And since then, I've not done. It can happen sometimes one specific case that I do open, but basically I don't do open. I do everything under arthroscopy.
Yes, Sanjay.
Yeah. Pascal, I have a kind of a philosophical question for you to especially help our younger colleagues in India. The whole of 1980s to 2000, the world swore by Bankart repair and said and there was a consensus that Bankart repair, open or arthroscopic, is the gold standard. Then 2000 to 2020, the world swore that Latarjet with 2 screws is the gold standard. That is the operation which cannot fail. And now you tell us that both are wrong and you use a third operation. What are your comments?
Thank you for this question.
Yes.
First of all, I still do the Bankart operation because what I have shown you is that I do the Latarjet plus the Bankart. So I've never quit the Bankart. I love this operation. I think it's a very important operation. It is important to recreate the concavity of the glenoid surface with the labrum. It is important to retension the capsule. But I do, in addition to this Bankart operation, the Latarjet procedure. So first of all, if you read carefully the paper on open Latarjet, the results are not so good as they were saying. If you even read the paper, the landmark paper of Carter Rowe, he mentioned, I think, 3 or 4% of recurrence, but that's not true. If you read carefully his article, if you add the subluxation, it makes 10% of recurrence at that time with very small follow-up with one of the master of shoulder surgery at that time. So the arthroscopic Bankart came, and I did many in isolation, and I was convinced it was the gold standard myself. But I reviewed my patients, and I was disappointed for 2 reasons. Reason number 1, some of them were stiff, and it takes a long time, 6 months to 1 year to recover, because I was so afraid of the recurrence of instability that I was over-tensioning the capsule. So I was limiting my patient, in fact, in motion, number 1. Number 2, there was some recurrences of instability. And number 3, in those who did not have a recurrence of instability, they didn't go back to sport, or they went back to sport and they stopped after 6 months or 1 year because they didn't feel their shoulder strong enough. So this was disappointing for me because, of course, if you look just at the recurrence rate, okay, you say it's 10, 15%, 20%, it's still acceptable. But then if you add those patients who are a little stiff, those patients who don't go back to sports, then you end up with 50% of patients who are not really happy with this operation. And after a while, I mean, when you do your own experience, you have to realize what is happening, and that's why the Latarjet is just a fantastic operation in addition to the Bankart. The difference between Laurent Lafosse and myself, besides the screw and the buttons, is that Laurent is resecting the capsule and the labrum, when he do his operation, when he does the Latarjet. And I don't remove the labrum. I don't remove the capsule. I keep it and I reattach it.
So today, if you have a patient who has, say, 4 or 5 dislocations, he is a bank manager and does not play any contact sports, has a glenoid bone loss of 10% and a small Hill Sachs, what is your choice of treatment, surgical treatment?
How old is he, you said?
He's 30 years old. He is a bank manager. He has a bone loss of about 10% glenoid bone loss, a small Hill Sachs, does not play contact sports.
Okay, but
what would be your line of treatment, your surgical choice?
If you add the glenoid bone loss, which is not much, 10%, but you must take into account the humeral bone loss with the Hill Sachs.
Small Hill Sachs, non-engaging small Hill Sachs.
Small Hill Sachs, and then you have to take into account the capsule elongation. So for me, it's an indication of arthroscopic Latarjet and Bangkok.
Thank you.
Yes, Ashish.
Pascal, 2 things. I have 2 questions for you. But firstly, the subscap spreader that you have designed is one of the sexiest instruments that you have designed, because it's very impressive. And to go through that 1/2 tube is very, very nice. The 2 questions, in case you're dealing with a failed Latarjet or somebody has a fractured coracoid, can you do the endo-button Latarjet with the iliacrus bone graft? And number 2, when you use the tensioner, have you ever inadvertently over-tensioned it and the suture breaks? Is that possible? Happened?
To answer to the last part of the question, no, it never happened to me. It probably happened to someone, I think. But we limit at 100 newtons. You know,
Yes.
on purpose. What happened to me that initially I was tensioning only once, and this is not enough because you have to take into account the creeping of the sutures. You have to take into account the tightening of the knot. So nowadays, I do at least 2, sometimes 3 tensioning with the tensioner, 1 for the creeping of the sutures, 1 for the compression, and if it's not enough, a 3rd one to 100 newtons. By doing this, I've never had observed any breakage of the sutures. They are strong enough. But again, the tensioner is limited at 100 newton. You cannot go further.
Yes. Yes.
I mean, the nice thing is that the drilling is very small. It's 2.8 millimeters, and you have 4 strands of sutures passing through this. So it's pretty solid, but the bone is not damaged with this technique. And the first part of your question was about
if there's a coracoid fracture, can you do it with a iliacrus bone graft? The same procedure? Have you done that?
Yeah. Of course. As I said, my first case was a failure of Latarjet, where I broke the coracoid bone block, and I fixed it with the button. It was the first time I did this with a button, because until that day, I mean, the buttons have been used to fix soft tissue like AC joint or syndesmosis in the ankle or ACLs. But I mean, nobody had never tried to fix both with that, and I was not sure of myself. That's why I follow my patients to make sure it will heal. And then after that, I designed a specific button, because when you put too much tension, if you use a regular button like an endo buttons, I mean, what's going to happen is that the suture is going to sew through the bone, through the coracoid, and the button is going to be tilted down the side of the coracoid bone block. While with the peg, the more tension you put, the more compression you have, and you have this sewing effect.
So Philippe Valenti is proposing to use 4 buttons instead of just the 2. So what's your thought on that?
Of course, I was sure that someone, and I'm happy that one day will come with 4 buttons. That's why I did myself before that. a prospective study with comparing two buttons versus 4 buttons.
Right.
And I'm going to publish this paper soon. And we have shown that there is no difference, neither in terms of positioning of the bone block or in terms of healing of the bone block.
Right.
So the conclusion of this study was clear. There is no benefit to put 4 buttons, so we don't do it. We have stopped to do it.
Right.
We just did it for the study. It's making the procedure more complex because you have more sutures, and it doesn't bring any benefit. So there is no reason that we do it.
And expensive.
As you said, the bone block resorbs superiorly. So if you put a superior button, it will be after a while it will be useless again.
So what is the percentage of osteolysis you have seen maybe 2 years after surgery?
No, we have, I mean, you mean complete osteolysis?
No, part, superior part.
I think it's all cases. It's part of the procedure. I mean, it's part of the process. I mean, the upper part of the bone block is not as well vascularized because the vascularization comes from the vessels inferiorly. Number one. Number two, based on the Wolff's law, I mean, there is no loads on the upper part of the bone block. So naturally it resorbs. It's not, for me, it's not resorption, it's remodeling, which is different.
Right.
Pascal, there is a question. How do you ensure there is no soft tissue interposition when you put the posterior button there? So soft tissue can come in between. So you don't use a cannula, you use a half pipe, helps you deliver it.
If you want, you can use a cannula, but I mean, for me, there is no, the button is not very big. It's 6 millimeter in diameter, or 6.5. I don't remember exactly. And so it passed through the soft tissue easily, and it has to pass through the muscle of the infraspinatus, which is very weak muscle fibers, so it's easy to pass through. It's small, again, it's very small.
Initially, did you do some cases without a tensioning device as well? And how were the results?
Yeah. The first series I did was without the tensioner, and I followed those patients again with X-rays and CT scan, and I was disappointed after a while because I obtained only 65-70% of bone block healing without the tensioner, and so I realized that just tightening the knot by hands was not sufficient, and that's how I get the idea of the tensioner, because I said to myself, I need something to really transform the soft structure into a rigid bar. And the tensioner gives me this possibility. And then using the tensioner, I observe an increase in the healing rate, but it was not perfect at first, as I said, because I was tensioning only once. And then I realized that I have to take into account the creeping of the suture and the tightening of the knot. And this is why you need to do 2 or 3 times the tensioning process to make sure you really have a good compression.
Pascal, there is a question from another one colleague, is that what is your post-op protocol in your hospital?
So the post-op protocol is the same than the open Latarjet, which means 2 weeks in a sling. Very important to put a sling in neutral rotation, not in internal rotation, because as I said, if you put the arm in internal rotation, the conjoint tendon is going to heal in the tendon of the subscapularis, and then it will limit motion. While if you put the arm in neutral rotation, the conjoint tendon is going to heal in the muscular part of the subscapularis, and you will not limit motion. And after 2 weeks, we let them do what they want. We tell them to go to the physiotherapist after 4 weeks, and we usually let them go back to sports at 3 months.
Yes, go back to sports at 3 months, yeah. Because even in the open Latarjet, people are telling that you have to go back to sports by around 6 months.
It depends of the sports, of course. It depends on the patient,
Yes.
but
Any question, IPS? IPS,
Yeah,
is there?
Pascal. They say that if there is a hyperlax individual, still would you do a Latarjet?
If you have a hyperlax patient
Yeah, yeah.
and no bony lesions,
No bony lesions.
yeah. So then that's a good indication for the 3-year operation. It's a partial, you do a partial osteotomy of the coracoid process, and you medullarize the bone block, and you lower the bone block, the coracoid process, but it's still attached superiorly, and it is still attached by the pec minor, so you don't detach the pec minor. And by doing this, you are using only the sling effect, not the bony effect of the operation. So
Last time when, yes,
it's a very nice operation because it can be done also with the button, and it's easier than the Latarjet because you don't have to pass through the subscap. You pass through the rotator interval, and you just bend the coracoid process down and medial.
I'm lucky, Pascal, that way that during my visit to your place, I have seen you operating that way. Basically, I understood this is the osteoclasis of the coracoid.
Yes.
Yes, I was lucky that time. Yeah.
Is that the Trilla procedure?
Yes, that is the Trilla. Yeah.
The Trilla.
Yeah, exactly.
Can we have an opportunity to have a look at instruments, Pascal? I mean, I was told you do have an instrument on the table around.
Do you have the instrument, Jackal? Do you have your any of your instruments set with that? Okay. Okay, so the thing is that in still in our country, probably for some issue with the guys, and anyway, we are not been able to use that set and the button somehow. So this is a request from our side, Pascal. You please look into that matter so that we can use as early as possible. Otherwise, again, we have to go to your place, relearn, and again we can use that.
But does it depend on the Smith & Nephew company, or does it depend on the Indian regulation?
It's both. It is both way. Both way. I think you can just tell those guys at your place so that we. Last time also I requested you that please see that it's available in our country. Otherwise I have to
awaiting FDA.
Yeah, no worries.
It's with the Indian FDA. They are waiting for final approval.
No worries.
Yeah,
There
I
are
know
two questions coming in. One question is, Pascal, what is your opinion about an arthroscopic bone block without splitting the subscapularis?
With the iliac crest?
Yeah, iliac crest. Do you do it in some cases, in revision maybe?
Of course, I do it sometimes, especially when you get a patient with a failure of a Latarjet, open Latarjet somewhere else, or you have a bone lysis, coracoid bone lysis. So it's easier, or it's also easier than the Latarjet because you're going to pass the coracoid, the iliac crest bone block through the rotator interval. So all you have to do is to open largely the bone block, the rotator interval, so that the bone block will pass easily inside the joint. And then it's the same technique with one button in the front, one button in the back.
Okay.
There's a question, how can you be sure that the single bone link gives a good rotation stability much more than two screws? So you can mobilize your patients with confidence.
So again, because you give good compression initially,
yeah,
and because you do the bank out procedure, so you have the two anchors for the bank out repair, and there is no possibility for the bone block to rotate. You know, if you have good compression and if you have the labrum there, the labrum prevents the bone block to turn. If you see what I mean?
And a question: have you never used two rivets? I mean, which is 4 buttons, as he said.
Yeah.
Never in your practice.
4 buttons.
You
He has already been.
No, he's done a double-blind trial.
Double-blind trial as well. Okay.
Yeah.
Perfect. So no more questions on the chat box here. So if you have any more questions, Ashish, Sanjay, because you guys are doing much more.
Yes, Sundar, do you have any question from your side?
Sundar as well.
Okay.
Yeah.
So I think Deepak, you just okay, Deepak. So I think Deepak will tell from our side because he is the another one senior guy like Sanjay and Deepak. Sanjay, please you tell your what is the take-home message as Prof has told us.
Like Pascal has a huge experience of doing Latarjet and all other forms of shoulder surgery. So this technique seems to be much more safer and perhaps a step forward than the technique using 2 screws. However, I still feel that arthroscopic Latarjet is still evolving. It is not for a relatively young newcomer. One has to be very familiar with shoulder arthroscopy at large and then embark upon these kind of techniques. And we really thank Pascal for his time and contribution.
Deepak?
Yeah, in my practice, the indications for Latarjet are not much, and I have a very limited experience, and that too with a open Latarjet. I think this arthroscopic Latarjet requires a very steep learning curve, and perhaps we have to visit him a number of times before we can, be a master in that. Yeah.
Ashish, your final comment on that, because Ashish is too passionate about the Arthro-Latarjet.
No, I'm a firm believer.
And me too. I'm too passionate about the Latarjet.
I have visited Pascal. I have actually seen all his results, and they were incredible. I can tell you that he does CT scans on all his patients post-operatively, so he has objectively reviewed them. Every patient that we saw had healed almost within 6 weeks, or sometimes even earlier, and the functional results were also good. I think he's a pioneer in this surgery, and so once this set comes in here, I think it's a good excuse for Pascal sometime next year to come back to India, and then that would be a good promotion for this technique, because when the founder promotes it, it will catch fire very fast. And so thank you, Pascal. Merci beaucoup.
Yes.
And au revoir.
Thank you, Jekyll.
Pascal.
Thank you, Pascal. I think this is a great honor, and you have accepted our invitation, and you have been really enlightened by your knowledge. And every time I talk to you, I learn many things. It is just a learning part. You are so kind that you have taught us. And Jekyll, last time, probably you remember that when he went for the human specimen, you have told us every step so that we can do it back in India. Thank you again. Thank you, Pascal.
Thank you, Pascal.
Take care.
My Indian friends.
Take care.
Thank you.
Thank you.
Friends, this was a wonderful demonstration of masterclass by Pascal. We do have another master tomorrow. He's Dr. John. Yeah, we are. Yeah, and
just for a second, wait. The other guys, they just leave the meetings. Then only will be.
That's okay. But this is an announcement for tomorrow.
Okay,
and
tomorrow.
It's a hip masterclass tomorrow. Dr. John O'Donnell is there tomorrow. We are starting between 4 and 6 p.m. and it's a advanced hip masterclass. Dr. John is incidentally the president of the International Hip Society, past president and the founder president. And we are lucky to have a pioneer in hip arthroscopy with us tomorrow. So tune in tomorrow at the IAS YouTube channel at 4 p.m. and enrich yourself with discussions and putting your questions in the chat box. Thank you very much and have a nice evening.
Thank you.